Good afternoon, everyone. My name is Chris Holsinger, and it's a pleasure to be joining everyone for this second chapter of the TORS webinar series. This is going to be broadcast on June 9th. It's being recorded sometime in the virtual world. I'm really excited to be participating in this panel. We're going to focus on controversies in adjuvant therapy, focusing on extranodal extension, margins, and a variety of other issues in 4 or 5 cases. I'm going to introduce the speakers here with Professor Joaquin Garcia from the Mayo Clinic representing pathology, Professor Meredith Evans from Cardiff in Wales. She is a clinical oncologist administering radiation and chemotherapy and is a really active clinical trialist in the United Kingdom. And PI with Terry Jones on the Pathos trial, which we may hear about later. Everyone knows Giuseppino Spriano, who's chair of otolaryngology head and neck surgery at Humanitas in Milan. And then finally, Jason Chan will be joining us from the Chinese University of Hong Kong. It's a pleasure to be co-moderating this with Katie Van Abel, and we'll just dive right in. Our first case is a 46-year-old man. He's a non-smoker. He's an occasional drinker, and he presents to your clinic with this single 3-centimeter lymph node and this endoscopic view that you see here. This is a first look at this lesion, kind of hard to see when you first begin the scope. And then on a closer up view, you see this lesion here. Jason, what are your thoughts now when you're evaluating this patient for the first time? He walks into your clinic.
So I guess just focusing on the laryngoscopic examination, I guess obviously looking for where the lesion is, its laterality, if there's a cross midline, how far does it extend into the follicular? If we can get that view, does it cross into the hypopharynx or into the larynx? Also would actually look in the mouth, and you want to see the mobility of the tongue as well, and if you can palpate it transorally as well. Those are some of the things I think I would consider right at the beginning.
Absolutely. And so great questions all. And when you put the scope in, you can actually see this really nicely. His pharyngoepiglottic fold is clear. And so this doesn't cascade down into the piriform sinus. That fold is nice and clean. The vallecula is clean. And when you actually have him protrude his tongue, there's actually no impairment whatsoever. You can almost, he's one of these guys that has great intraoral opening, and you can almost see this thing sort of in the back. And so you can use the narrowband imaging to take a slightly better look here. What do you think about narrowband imaging? Do you use this at all in your initial staging for these tumors?
So I use narrowband imaging. I've started using it quite a lot. I think there are some nuances to the scopes that we have in ENT. If you compare them to the esophagus scopes, there's some problems with the ENT scopes with narrowband imaging. You can see dilated vessels, you can see brown spots, but it doesn't help you much in comparison to white light, I don't think. And if you look at the Japanese literature with ELPS, around these areas with the crypts is actually quite difficult sometimes to see with the scopes. I've done some work as well using the esophagus scopes, and you actually get a much better detail. You can magnify and zoom into these much clearer with esophagus scopes. So and you can do that transorally as well with the patient awake. So OGD scopes, I think, are much more useful than the laryngoscopes we have. And I think MBI with our current scopes have a limited role in delineating the margins of these particular tumors. And the other thing is some of this may not be completely mucosal with lymphoid tissue. So you can't really delineate the margins very well with MBI is my thought on using narrowband imaging.
And that's why the NBI was used here to try to figure out, is this part tumor here? I mean, this clearly looks like tumor here if you can see the mouse. But I agree. I mean, it'd be nice to know that. We don't really have a way to get a good sort of optical biopsy. So this patient goes on and has an FNA of this neck mass right here, and that's read out as P16 positive squamous cell carcinoma in this single metastatic node. This case is sort of old, so we actually don't have a PET scan even for this. So we now know this is a P16 positive HPV related oropharynx cancer. Given the limitations of, seeing a couple slices of CT scans and that endoscopic view, what does the group think is the next most appropriate step in management? And I'll just remind you, this is a P16 positive cancer in a 46-year-old non-smoker. Merdad, you gonna radiate this guy?
I'd like to see an MRI scan to have that tumor defined. What is the stage of that primary tumor, Chris?
He has been staged. He can't sit in that MRI, just really claustrophobic, and so we'd love to have that better. Why did you want an MRI, Merdad?
I mean, that CT scan didn't seem to very well define that primary tumor. So, we have the endoscopic view, but not a kind of cross-sectional imaging view of whether that tumor is going into extrinsic tongue muscles and whether it's, a kind of a T4 tumor, a kind of more advanced T-stage tumor where, we'd be trying to steer the surgical team away from transoral surgery.
Right.
I wonder if we could talk about that or take a poll there, because I think MRI raises some interesting concerns, and there's some question about whether it can overcall tumors by showing some of the edema around the tumor. We would typically not get an MRI, but that's just provider preference. Would other people get MRIs for the initial workup of these tumors? Jason or Giuseppe?
I would.
I mean, it would be fairly standard practice in the UK for an oropharyngeal cancer.
Giuseppe, what do you think?
Yeah, I agree with the previous speakers. Usually, we use always MRI for staging, and I think that the problem of classification is that the involvement of extrinsic muscles, like even the glossopharyngeal muscles that lies into the anterior pillar of the tonsillar fossa, the tumor become T4. So I think that we have to discuss if it's appropriate you see the TNM classification in order to assess the T4 of the oropharynx. So, for tonsillar fossa, it's very easy even for a small tumor to involve the pillars. And so you can have a T4 that is a very small T4 comparing with the T4 for invasion of the bone or some other deep tissue. We use routinely MRI, and we check the deep of infiltration, even if it's not so codified as in oral cancer, but if the tumor go deeply into the extrinsic muscles, so this could be a contraindication for us for using transoral robotic surgery. So if the tumor is small, it's less than T2, that means less than 4 centimeters without deep invasion of the extrinsic muscles, so we can use a robotic approach, even because the nodes seems not to have an extracapsular spread. And so if we are dealing with T2 and 1 base of tongue tumor with P16 positive, you know that we have two options. One is robotic surgery transorally with neck dissection versus radiation. And you know that there is a trial ongoing in RTC that Christian Simon is the PI, in which, and we are a participating group in which we are randomizing the patients of these tumors in order to receive radiation versus transoral robotic surgery plus neck dissection. So I think this is a typical case in which both the approach can be considered equivalent.
So, thank you, Giuseppe. So, Meredith, Jason asked some very focused questions, and this guy didn't have an MRI. He couldn't sit in that scanner. We often get them. But would you believe the clinical exam if you could put your finger back there, see right into that vallecula, and watch that tongue move without impairment? Would you believe that it's not a T4 and a T2? Do you have that much faith in physical exam, or do you have to have better imaging as a radiation oncologist?
As a radiation oncologist, I would like to see imaging, but I appreciate that it's not always possible to have optimal imaging. But, you know, when we plan our radiotherapy, we can't plan our radiotherapy based on, you know, I mean, the clinical description is important, but, you know, we draw our volumes around the radiology.
So this patient is 46, and after a long discussion, you know, someone talked about just doing radiation therapy alone. We have this radiation oncologist who trained at MD Anderson, and she says, "Oh, well, you know, chemo, you don't really need chemo a lot of times. That's a small node. That'll just melt away." But there was a lot of discussion about using a full dose regimen with cisplatin, and even someone actually talked about induction chemotherapy. What would the group, Jason, what's your vote for this guy, for this 46-year-old P16 positive?
I would go with surgery up front for our institution here.
Would you treat both necks or just one neck surgically?
Surgically, it looks lateral enough. I mean, I would treat one neck for this gentleman. I know that post-operatively, he would likely get RT to the other side with our group here.
Meredith?
Yeah, so I think, like Giuseppe said, within Europe, you know, including the UK, this patient would be eligible for the best of study, which would randomize the patient into radiation or transoral surgery. So I think that just shows that both there's equipoise between both those treatment options. So we would, in our multidisciplinary team, discuss both options with the patient. And, you know, in an individual patient, think about the pros and cons. In a 46-year-old, surgery is, of course, tempting, you know, but one would want to try and avoid surgery followed by adjuvant treatment. So if we thought that this was going to be unimodality surgery, then, you know, that would be an approach that we would support. But I think one would have to also offer non-surgical treatment for the patient. So within best of, for a T2N1 tumor, the patient would have 70 gray of radiation, but delivered over 6 weeks. Outside of study, there is definitely a case to be made for concurrent cisplatin, given with 7 weeks of radiation. You know, the RTOG and De-Escalate studies, which randomized patients between cetuximab and radiotherapy and cisplatin and radiotherapy, showed a significant survival advantage to cisplatin. Wasn't compared against radiation alone in this patient group, but, you know, one would have to be a little bit apprehensive about omitting cisplatin, I think, in somebody who would have a good prognosis if appropriately treated.
Fantastic. Well, and Joaquin, you're coming up next here. So thanks for that great overview of all the options. And again, it's really a pleasure to have true international representation in the multidisciplinary panel discussion today. I think, you know, it's always great to look beyond your shores to get a fresh perspective on these things. And that's the real value, I think, of getting everybody together today. So this patient is young, and he's come to us for a surgical opinion, and based on the group, it feels like surgery might not offer unimodality therapy, but because he's 46, to avoid some of those late effects of radiation therapy, to full dose radiation therapy, he wants to go ahead and proceed with surgery. And I've just got a couple of quick questions for the surgeon so we can get on to pathology, the surgical pathology, to get Joaquin's perspective. A neck should be done. Katie, what should we do for the levels that we dissect for this patient? Are you going to do unilateral, bilateral, and of those necks, which levels will you dissect?
Well, we would definitely dissect the ipsilateral neck. We would dissect level 2A, 2B, 3, and 4. if there was anything concerning on imaging in any of the other levels, then we would dissect those on a case-by-case basis. Then I think the discussion would be if we felt like this patient could be somebody who was treated with surgery alone, then we would consider doing the contralateral neck at the same time. If we thought this patient was going to be receiving adjuvant therapy, or that was where the patient and team were leaning, then we would dissect the ipsilateral neck alone. And then I agree with Jason, likely go on to radiate the contralateral neck. We offer a shorter course of adjuvant radiation therapy for patients who meet criteria. And so we might be able to offer a 2-week course of 30 to 36 gray with docetaxel if the patient didn't have any, or had only a single node or no significant ENE.
And I think many people are learning of this Mayo approach with very de-escalated post-operative radiation therapy plus docetaxel. Do you want to talk briefly about that, Katie, before we move on for other speakers to talk about the neck?
Sure. So we've completed both a phase 2 trial. It was published in the Journal of Clinical Oncology, looking at our aggressive dose de-escalation protocol. That study had 79 patients. It was single arm, where all patients underwent a study protocol. Patients were P16 positive, less than 10 pack years, no distant disease, and were surgically resectable. Then they were randomized into an intermediate risk group and a high risk group. The intermediate risk group had things like T3, T4, PNI, LVI, something like that. And then the high risk group had any presence of extranodal extension. So there wasn't a cutoff, which hopefully is a segue to what Joaquin can talk to us about, but just any presence of ENE. The intermediate risk group underwent 2 weeks of radiation given in twice daily doses with 30 gray and docetaxel. The group with extranodal extension got an additional boost to 36 gray in any of the nodal basins that had ENE, also with docetaxel. We followed that out and have reported our 2-year outcomes, both from an oncologic and a functional standpoint. And from an oncologic standpoint, we had 99% overall survival. There was a 91% progression-free survival, and local, regional, and distant metastasis-free survival were both excellent as well. And then what was really exciting was the functional outcomes as well. There was only one patient had a PEG tube that was out within a year. Xerostomia scores on patient-reported outcomes dropped to baseline, or to baseline by a year afterwards, and stayed at that level for 24 months. So that's what our initial study was. We went on to do a prospective randomized controlled trial where patients received the study course of de-escalated therapy or 6 weeks of adjuvant therapy to 60 to 66 gray with cisplatin. And hopefully we'll be reporting on those soon.
Yeah, I mean, it's really exciting work, Katie. And I mean, the fact that Mayo's got this in phase 3 is going to be really provocative, especially as we see 3311 come out, pushing us down to 50 gray post-op. Perhaps we will be able to continue that discussion later today or some other time. But for the surgeons, are you dissecting, you going to do radical neck or selective? Are you going to do level 1B, Giuseppe? Are you going to do 2 through 4? What's your approach for a standard TORS neck dissection for a patient like this who's getting unilateral treatment primarily to the neck, expecting contralateral post-op?
Yeah, no, in this patient, because of base of tongue and the tumor seems to be less than 1 centimeter to the midline, and because of one node's clinical evidence in one side, I will do bilateral neck dissection, selective bilateral neck dissection. We use unilateral neck only for tonsillar fossa tumor and 0 or N1. But in this case, because the tumor is rising from the base of the tongue, if the tumor is far more than 1 centimeter, so we can use unilateral. But if the distance in MRI is less than 1 centimeter to the midline, in this situation, we prefer to do a bilateral neck dissection. Regarding the dissected level, officially, a lateral selective level 2, 3, 4 is considered enough even in N1, but you know that in the practical point of view, it's very easy to dissect even level 1B, preserving the submandibular glands. And when you pull the sternocleidomastoid muscle toward you, you can go over the lateral aspect of the sternocleidomastoid muscle itself, and so you can remove even a small part of level 5. But officially, I think that lateral neck dissection 2, 3, 4 has to be considered adequate. So in both sides, the lateral neck.
This is a busy slide, but I think you anticipated exactly the point here, which is that, you know, we don't need to be dissecting those pre and post facial nodes, but it's important to try to come over and slightly medial to that lateral edge of the submandibular gland to get that full neck dissection. And so that's what was planned for him. Katie, during consent for surgery, you're also discussing how you're going to manage the known risks of post-operative hemorrhage. How would you manage this patient? Would you just manage the bleed risk transorally? Would you do anything during the neck dissection, ipsilateral, contralateral?
Yeah, thanks. I think that we all need to be really aware and counsel our patients well on post-operative hemorrhage. We typically, with the SP now, we can use bipolar on anything, you know, sort of smaller, anything that's 2 millimeters or larger or has any name associated with it gets transoral clips. And then we have started back in 2013 going to the neck ipsilateral to the tumor and ligating prophylactically branches of the external carotid artery. It depends a little bit on the tumor. If during dissection, you know, the external carotid is real close to the tumor, we might ligate that. But typically for a base of tongue tumor, I would be ligating the facial artery, the lingual artery, and the superior laryngeal. And if I can't see it really clearly, I just ligate the superior thyroid right at the takeoff from the ECA. Talk a little bit about first bite syndrome or the potential for that with patients. But Chris, we did lose your slides.
Yeah, I thought, yes, okay. Thank you. Thanks,
okay.
Katie. Yeah. I wanted people to focus on your content.
Okay.
No, exactly. not a bunch of text.
Got it. Yeah. So that's what we would do. I mean, and that's based on some of the initial TLM hemorrhage rates that, you know, were coming out of Mayo, Arizona and with some colleagues. And I think that we just need to make sure that we're looking at the tumors, we're looking at the imaging, and not being so dogmatic that we won't sort of branch out and take another branch of the ECA if we need to.
Great point about the superior thyroid too, especially if you go down deep into the vallecula. Yeah, really great point, and a question that goes back to Jason's first observation about the extent of this tumor down toward the vallecula. And I think just to review some of the data here, this is a great paper by the Pittsburgh group, you know, showing that you know, by prophylactically ligating these patients, you're still going to have some small level of hemorrhage, but basically the catastrophic hemorrhage is significantly diminished here in this paper from Mundal et al. And then I think that the Oregon paper, of course, Neil Gross is now at MD Anderson, but I think this Oregon paper really makes the point that when we're prophylactically ligating these branches, that it really does drop almost to zero the severe bleed rate seen here in black. Major bleeding in both groups, ECA ligation versus no ECA ligation. There's relatively the same amount of, you know, major or intermediate bleeds, a significant though decline when you ligate these, basically limiting that grade 4 potentially deadly postoperative bleed. So really important. We don't have time to talk about this, but notice everyone is talking about ligation. We're not cutting these. Many of us are not cutting these vessels. We're just simply ligating them. And is Jason, Katie, and Giuseppe, is that how you're doing it? Or are you identifying, cutting, and clamping and tying each end of these vessels?
No, I'm ligating. I'm not cutting the ends. Yeah.
Katie, same for you?
Same.
Yeah. Giuseppe?
Yeah, if the tumor is large, and so if the resection is deep, I prefer to ligate the external carotid artery routinely, because the only big problem is the fatal death of the patient for
Got it.
bleeding. So I prefer to ligate external carotid artery, even in this specific case in which the probability to use adjuvant radiation is small, because we didn't see in the imaging extracapsular spread. And if we use a frozen section of the margin, so if we are dealing with R0 and extracapsular spread negative, so the probability to use radiation is small. So in this case, I prefer to ligate the external carotid artery.
Got it. Thanks.
And I'll just add one more bit as far as ligating. If I feel like the facial artery has a lot of contact with where the tumor is, sometimes I'll ligate it again distally, just up near the mandible, because I think you still can get a lot of retrograde flow. So occasionally I'll do that, but it's all just a single suture.
We have got to continue this discussion so important, Katie, about this back bleed, because I used to do the ECA only, and I definitely do sometimes the ECA plus the terminal branches. And but we'll have to move on with this case, but a really important discussion, I think, for next time. So surgery then proceeds, and I'm gonna try to share my screen here one more time. See here we go. And this is the resected specimen. There's a big question mark here. What the heck is this? Jason asked earlier, like, well, is all this tumor? How do you map that? Do you biopsy it? Who knows? But for the purposes of the discussion here, I have, this is my case. So I've resected this tumor. The patient had a partial excision up here. You see the scar tissue. I use the margin marker set. So this is a midline medial edge here with yellow, orange, lateral, superior red, and inferior down here at the vallecula and the epiglottis down here. This patient actually was enrolled in 3311, and I sent this entire specimen for Frozen's, and asked the pathologist en bloc to take margins circumferentially around that. Joaquin, is that a fair question for me to ask, to send this huge thing and expect a pathologist to actually, in a reasonable amount of time, assess the margins of this superficially and deep?
Well, Chris, thanks for the question. Well, the needs of the patient come first. So if that's what my surgical colleague needs, and that's what we got to do. So I think probably the more profound and challenging question is, what does that mean? What is a circumferential margin? A circumferential, do you want us to take representative perpendicular sections throughout that specimen? That's asking a lot, right? That's dozens of slides. If you're asking us to do an en face margin, meaning I take my scalpel and I run it along that yellow line of the specimen, I can do that in one slide. It really kind of, the second question is, what type of circumferential margin are you asking for? And I think the answer to that is based on your understanding of the biology of the tumor. What type of tumor is this? What did you see on imaging? What margins are you most concerned about? For example, you might not say, I don't want a circumferential margin on this entire specimen, but I want super thorough margins laterally or medially. And maybe there's more bang for your buck there. And if you're worried about deep, obviously we'll go after that. But as a pathologist, I have no idea if you're going to submit additional margins as well, which really gets to the point that I've heard many times in the last, 20, 30 minutes. Understand what your colleagues are seeing, whether it's based on imaging or intraoptically. So that communication is really going to lead me to make the right decision here, Chris.
It's a beautiful summary, and what a great approach. Katie, you're lucky to have Joaquin right there, right next to you, as you mentioned earlier. What about deep? Like, I sent this, there's this irregular surface, and I've gone deep to the constrictor up high as I approach from the glossopharyngeal sulcus. I'm lateral to the constrictor, but then as you go out into the tongue base, fortunately, Meredith's concerns were fortunately not seen. This was really superficial tumor. It's this exophytic kind of thing. But is it possible in a in a topographically complex wound like this, can you really get a deep margin during frozen sections? Like here I've sent a superior constrictor and it was read as negative. I mean, what do we do for the deeps?
I guess when we assess the deep margin, sometimes it's easy, sometimes it's really difficult. It's a function of the type of tissue, really. So if this conversation were about breast tissue, you can imagine fatty tissue just falling apart. It's kind of the opposite here. Now we have skeletal muscle and in some areas even smooth muscle. So that muscle is starting to constrict. So for me to determine that you have tumor at a deep margin, I most likely put ink along that specimen. Between the time I put the ink on that specimen and the time I actually interpret the slide, there's actually a lot of activity, as you know, in that tissue. So sometimes it can be challenging, it can be very variegated, and the ink can drip down into the specimen, the crevices.
Yeah. And so, this is the final report. Our mucosal margins were greater than 3 millimeters. This separately submitted deep margins were negative. There's no LVI, PNI. There were 2 positive nodes of the 31 dissected without an extranodal extension. But during tumor board, like where everybody's happy, patient's happy, it says the margins are negative, but let's dig down a little deeper. I'm sure Meredith, this is what she would do. She would say, okay, that's nice. That's the synoptic, but let's take a look at the numbers. Meredith, I know this is the first time you've seen this. What do you think about all this? And I've highlighted everything that over the years, my radiation oncologists have pointed out when I say, oh, but the margins were negative. The margins were negative. Am I clear here?
So, I mean, if I'm understanding this correctly, these are visual margins, are they? The 0.2 centimeter from the superior margin?
Yeah.
Is that right?
Correct.
And so I guess that clinical, whether they be radiological or clinical margins are trumped by the pathologist, or that's what our pathologist tells us. And, if the pathologist says that the margin is clear, then I would be happy with that. If this was 2 millimeters from the superior margin, I would, consider that a close margin. And I'd be almost certainly contemplating adjuvant treatment.
Yeah. And if it's a little close there along the superior margin, would you still say it's 60, or would you want to bump up to 66 gray?
For the dose of radiation?
Yeah, for the post-op dose.
So I think the data that, Katie, you talked about from the Mayo Clinic is really interesting. The phase 2 data. Outside of the context of the phase 3 clinical trial that you're running, then I would say that the standard of care would be 60 gray of radiation to a close margin, a 2 millimeter margin like this. Based on what is quite old data by now, the RTOG randomized data, which shows that an operative bed should be given at least 57.5 gray of radiation, which most oncologists now interpret as 60 gray in 30 fractions of adjuvant treatment. Of course, in the context of HPV positive disease, that's been, the ECOG 3311 study has demonstrated that in a phase 2 setting, 50 gray seems to be enough in that intermediate risk group, so long as there's not a positive margin or extracapsular spread. And the PATHOS study in the UK and internationally, and hopefully soon in Stanford and in other US centers, will kind of confirm that finding from ECOG 3311 in these intermediate risk patients having adjuvant treatment.
That's great. And so, in fact, we actually launched PATHOS yesterday here. So I'm really excited about this. So this patient was actually on 3311, and he was considered in the intermediate risk group with his pathology. And he actually had 50, he ended up having 50 gray. He was randomized to that Arm B, and now he's 6 years out and is free of disease. So next case is, and we're doing a very deep dive into these cases, which I love the discussion. Rather than go through like 10 cases and gloss over them, we're really taking a deep dive. So thanks everybody for doing that.
Chris, can I make a quick pathology comment?
Please.
On that last case, I noticed on the imaging, it was a 3-centimeter node. In the pathology report, there was no extranodal extension. It's probably a good time for me to tell the audience that E33 recommendations are for a 2-centimeter node or less, you need at least 1 slide. For every additional centimeter of the lymph node, you need at least 1 additional slide. So in our practice, and E3311, we would suggest there's at least 2 slides for that 3-centimeter node. Just a good public announcement.
Huge, huge. And you know what, Joaquin, we may be discussing that further in this next case, which is a 58-year-old gentleman with also a right neck mass, also never smoker, also not a heavy drinker. And you see here on exam, this was sent to one of us as an unknown primary tumor. But you look in there, I know the endoscopic view, you see this very obvious primary tumor in the tonsil. Here's his PET scan, and hopefully this imaging is better redacted than the last case. I know how important images are for radiation oncologists, clinical oncologists. Here's his PET scan here showing the primary tumor, and you see this really nicely rounded single level 2 lymph node on the PET scan. Perhaps a little less regular as we go sort of down in the neck. I know, you know, for the purposes of the discussion, we've glossed over a lot of things that we've covered in the earlier cases, but 58 years old, single hot node, P16 positive. You saw the tumor, it's a 2.5 centimeter tonsillar cancer. Bernadette, are you finally going to get your shot to radiate in this panel? What are you thinking here for this guy?
So it was a tonsillar primary.
Tonsillar primary, correct. Yeah.
Okay. So in our practice, we would offer this patient the PATHOS study, which would be upfront transoral surgery, neck dissection, followed by risk stratified, de-intensified adjuvant treatment. And so that would be our practice. Of course, primary non-surgical treatment is another very good option that has to be offered up front to the patient. But if the patient was going down a surgical route, we would offer entry to the PATHOS study for him.
And I'm going to pull up the PATHOS schema right now here. If I can find it in real time. Katie, what are your thoughts on this case?
Well, I was just going to, we would offer most likely a surgical management with transoral robotic surgery, ipsilateral neck, select neck level 2 through 4, sorry. Prophylactic ligation of the vessels that we talked about. And then based on the pathology, we would offer adjuvant therapy. And something that we've been interested in is looking at how good we are at identifying radiographic ENE versus pathologic ENE. And so I was just curious what other people look for when they're looking at their imaging to help them feel more or less confident that there actually is ENE present based on imaging.
Jason, any thoughts on that?
So I guess I would do the same in terms of surgical treatment management of this patient, but in terms of the ENE, we actually get a lot of MRI for our patients, and I think in general it's part of our practice. We have a lot of NPC patients, so MRI is what we're good at. So MRI is where we go to, and I think based on the MRI, I do agree we do overcall it, particularly around tumor edema. But in terms of ENE, I think it's probably much better to identify and see radiologically, and they're much better at calling ENE with the MRI here when they look at it. But I do agree with the overcalling of tissue edema for tumors in that sense.
Yeah, thank you. Bernard, here's your schema for PATHOS. I was a little slow on the draw now, but if you'd like to just take a few moments to walk us through some highlights in the middle of our discussion here.
Yeah, so great. Thanks for the opportunity. So this is a phase 2 study that has now transitioned into phase 3. And it is looking for patients with, T1 to T3 transorally resectable, P16 positive oropharyngeal cancer with ipsilateral neck disease. those patients are being offered transoral surgery and a neck dissection, and then they're being risk stratified, not unlike ECOG 3311, patients with low risk pathology. And that is working out at around 10% of the patients have no adjuvant treatment. And we've seen in ECOG 3311 in the reported results that those patients have good outcomes. In the intermediate risk pathology group, patients are randomized between 60 gray of radiation, which is the standard of care dose of adjuvant treatment in these patients, and 50 gray in 25 fractions. So that intermediate risk group is very much like ECOG 3311, and it would be nice to think that we could meta-analyze the data from both these studies in the future. And then in group C, these are patients with high risk pathological features. So this is margins less than 1 millimeter around the primary tumor, so positive margins, and or extracapsular spread, and that's any degree of extracapsular spread as called by the local pathologists. And these patients are randomized between adjuvant chemoradiotherapy, so 60 gray of radiation plus concurrent cisplatin, or adjuvant radiation alone. In the high-risk group, there is an option to boost high-risk areas to 66 gray. You know, some people are advocates of that. Some countries are advocates of that. Others stick to 60 gray. The evidence base is gray, really, around the need to boost to a higher dose than 60 gray. I would say that, you know, the study now is open in France, it's opening in Germany, it's open in Australia and the US. And so, you know, we're really excited that it will be a truly international, you know, set of results that hopefully we can all kind of use to guide our practice in the future. We've recruited so far around about 500 patients. We need about 1,000 because it's a non-inferiority phase 3 study design. These studies need lots of patients. Thanks,
well,
Chris.
congratulations. I mean, it's such an exciting study, and you know, we're excited to join. And I think especially as 3311 is closed and we await the phase 3 data from Mayo, I think Pathos is really one of the most important trials really underway in surgery. So in this patient, you see here, we've had a discussion of margins already. They're considered negative. And you see that there's only one positive lymph node, and despite that nice rounded edge, there's exactly 2 millimeters of extracapsular extension. Now, I've used the word extracapsular extension here because way back when, that's what we were calling. This is a 2016 case. He was staged in the earlier 7th edition as a T2 and 1. And so the next step we're going to talk about is in how we manage this patient. You know, a variety of options we're going to cover in just a second. I'm just going to get them out here. But Joaquin, you know, here's a paper as we discuss this issue of extranodal extension and no other adverse features, good margins. How do we interpret these data from Dr. Lewis in this 2015 paper? You know, there are multiple extracapsular, you know, there are multiple schema for how we classify this. What should surgeons take away? I mean, you really emphasized an incredibly important point earlier. What are your thoughts on this paper about how we classify it and how we manage this disease?
Chris?
Yes.
Chris? Yeah.
Yes.
Yes, we have seen this paper, but 30 years ago, when you was a baby, there was a paper from Carter, was a pathologist from UK, that has already demonstrated that minimal extracapsular spread is very similar to the patients without extracapsular spread. So there was already a difference between minimal extracapsularity versus large extracapsularity. So this is a paper that you show now is very similar to the oldest one. But I think that in this panel, in which we have to focus on extracapsular spread as well as a free margin of resection, and we usually used to do full free margin of resection. That means to check the margin on the specimen, as you have shown it, and the resident who has participated to the surgery go to the pathologist to check together. Then we add even free margins of resection on the bed of the patients in order to obtain a double free margin of resection, because the major risk is to have the necessity to deliver chemorad in adjuvant setting. And the paradoxical situation is that these patients, like this one or the previous one, if was recruited in the best of, and if radiation would be chosen, had less therapy comparing to the patient who underwent surgery with positive margins or extracapsular spread. So we have the paradoxical situation that patients that are in best off with involved marginal resection, extracapsular spread, received an highest treatment comparing to the patient randomized for the arm of radiation alone because of extracapsularity and because of margin of resection. So in this particular case, we will deliver radiation alone, avoiding chemo because is a minimal extracapsular spread, and because these patients in best of had been receiving only radiation instead of chemorad.
And so, I've clearly got to go back and read those papers that came out when I was in diapers, Giuseppe. I definitely need to do that. But while I'm doing that, Joaquin, what do you think about help? You made a really important point that the surgeons need to really have that communication with their pathologist, not only intraoperatively, but postoperatively, when understanding this minimal, like Giuseppe said, this is a 30-year-old story, and we're just now starting to think, oh my gosh, there are these classifications of ENE. What do these pictures from this paper have to teach us as surgeons about how we think about this disease?
Thanks, Chris, and thanks for the excellent comments, Giuseppe. I completely agree that my pathology predecessors pioneered a lot of the thoughts that have hit the literature runway in the last few years. When we think about extranodal extension, it may be easiest if we start with the ends of the spectrum. So if you look at this image on A, in that box A, that's one end of the spectrum, and then D is the other end of the spectrum. So in A, you see a lymph node, and we know it's a lymph node because it's rounded, and you also see collections of blue cells in there. The tumor is all within the rounded architecture. So I would regard that as a tumor deposit within that lymph node. D, on the other hand, doesn't really have any suggestion of lymph node parenchyma at all. Not even now, but even previously. So I don't see what I would resemble to be a capsule or the collagenous stroma that makes up what we regard as a capsule. I don't see any germinal centers. So those are the ends of the spectrum. Those are the easy cases. Those are the cases that a pathologist can typically look in a black box and say, no ENE, or yes, this is extensive ENE, or even better, this is a soft tissue metastasis. It's really the images in B and C that I think bring up the challenges in this process. And Dr. Van Abel, having spent multiple Sundays with the head and neck pathology group, she can see these in action. In B and C, you're trying to figure out if there is minimal extranodal extension or just a fibrous rind around your tumor deposit. You have to at some point draw a line. And that's why you see a line on these two pictures in B and C. A and D were so obvious you didn't have to. So when you draw your line in B and C, you are effectively speculating where you think the limits of that lymph node end. So if you start from the core of the lymph node and you move out, you start to lose confidence that you are in the lymph node. You might go through some tuberculae, some sinuses, some germinal centers, and then you're seeing it rounded. You're seeing these collagenous fibers. Okay, that's a normal lymph node, but then it starts to get thick. Okay, wow, is that an immune response? Is this a fibrotic response to a tumor deposit that has a broad front pushing the lymph node? Or is this just the way that the lymph node was cut? Maybe it looks thicker than it is. Not really sure. So that gets a little fuzzy, right? That we would see on B, where the line is drawn around the tumor deposit, and just outside the line, you can see this pink rind. Okay, and so we're left to think, wow, is that a reaction, or is that just kind of a thick capsule? In C, you can see the pathologist drew the line again, and they confidently drew the line around what they think is lymph node. So you have a lot of blue cells in there, and everything to the left of that they think is outside the limits of the lymph node. So everything beyond that is most likely just tumor and fibrosis. When does that become challenging? That becomes challenging. Let's say that is in fact extranodal extension, extracapsular extension. That tumor is out of the bag. We're in C, we're out of that dashed line, we're headed to the left, but your body can actually have an immune response there. There can be lymphocytes that come into that tumor, and there can be germinal centers that form. So now the pathologist is no longer able to work in a black box. They really have to push on all the intel available to them. So that's when we have to lean on the imaging. We want to know the size, the suspicion of whether or not adjacent soft tissue is involved. Of course, I want to talk to my colleagues, see what their suspicion is. Sometimes I even call my, when I say my colleague, my surgical colleague, sometimes I even call Rad on and say, where are you with this patient? Okay, because I'm kind of on the edge here. I don't have enough data. So B and C, I think, are the areas we really need to rely on each other as experts to get to that decision.
Wow. Thank you so much.
And I think that really points out some of the challenges with ENE. And I'm fortunate to work with Dr. Garcia, who looks at a lot of HPV positive oropharynx cancer patients. But Joaquin, I wonder if you could comment on just based on that, why there's so much inter-rater variability and why this sort of hasn't taken off as a standardized grading system that we use universally. I think you've already hit on those points, but I think it's worth repeating.
Sure. Well, I think like anywhere else in our profession, the more you do it, the better you get, at least the more reproducible you get. And of course, if you're in a group with a couple experts, that helps. Here at Mayo Clinic Rochester, I'm fortunate because I'm one of 4 head and neck pathologists. I rank in the top 4. But it often requires, as you know, you probably do it within your expertise as well. It often requires bouncing that back and forth. So I worry about patients or hospitals that may not have the communication infrastructure set up like we have in our respective institutions. Pathologists that may not have the experience, may not know the gravity of the call, may not know what P16 positivity means for, management of patients now, just because they're not in that conversation. So I certainly do worry about that. When we get into our zone, we do bounce it off each other occasionally, the 4 pathologists. But a good example of when we meet our limits is, let's say, if you go back to that picture, Chris.
You bet, coming right now.
So Chris showed us in number 1, this is a tumor deposit confined to the lymph node. I think most of us can confidently say, look, there's no fibrosis around the lymph node. I think that's a capsule, that's fine. So that's probably about I don't know, maybe a 2.1 centimeter node, let's say. But what if Dr. Van Abel gives me a 6 centimeter node and it looks the same?
Great point.
Around it. There's not a thick rind around the capsule, okay? And there's no fibrotic response, stroma. Boy, this is really challenging because if I work in a black box on the pathology rules, there's no extranodal extension. Got to know the size of that node. I got to know the imaging. I got to know what my clinical colleagues are thinking. If I am stuck with the pathologist rules of saying no ENE, in a situation like that, I'll probably invoke the verbiage of no definite ENE observed. And I'll make a comment on, we need to put this in context. Is this an extremely large node? And I, as a pathologist, cannot discern a tumor, an invasive broad tumor front with no immune response versus a tumor deposit that's so large, it's actually contained within the collagenous stroma of the capsule. So I'll have to put that verbiage in a report on occasion.
Okay for me to speak?
Please.
Yeah.
Please. As always.
Hello. So I just wanted to go back to the clinical scenario again, because it was suggested that this patient may not need adjuvant chemoradiotherapy. And I think if Dr. Garcia, in his expert opinion, told me that this patient had 2 millimeters of extracapsular extension, then outside of the context of clinical trials, we should be offering this patient, or I would be offering this patient as the lone oncologist on the panel, adjuvant radiotherapy with concurrent cisplatin chemotherapy. I think that is the standard of care based on the R2G and the EORTC post-operative chemoradiotherapy studies. admittedly not in the context of HPV disease, and that's why we need prospective studies to give us the evidence base for the future, but the evidence base that we have currently is outside of clinical trials. That's what this patient should be offered.
Really great point, because that's where the data take us. And I think just, we only have a few minutes left, and thank you for making that point, is because yeah, maybe we can get by with RT only. There's a long literature dating back 30 years to demonstrate that, apparently. But yet when we go to the NCCN guidelines, you know, they say systemic therapy should be given for this process. And it's not an infrequent finding. This, just to, as we wrap this case up here, you know, in this large database review, you know, basically a quarter of the patients operated on ended up having extranodal extension across this United States experience. And yet we're relying on this data, two New England Journal papers published in 2004 that say, hey, look, you know, if you got extranodal extension, you know, and you have these high risk factors, you really need to have cisplatin. But yet, you know, obviously the WashU group has, with their 152 patient experience, shown well, maybe you don't need it. And there's this paper from Carter et al. In the UK that says not. But, you know, I'm just going to quickly come to this slide here, looking at this large scale database. This is this provocative study from the NCDB, I believe, by Yi-An, the radiation oncologist from Yale, that shows that very clearly patients with extranodal extension do worse. Right? There's this clear difference in overall survival, 89% with ENE, 94% without. Now, granted, that's only about 5% difference. But what's interesting, though, is in this large scale data set, again, not a randomized data set, there was really no significant difference when radiation therapy was given alone versus concurrent. And therefore, I think, just as we wrap this case up, your study in Pathos is going to be really critical, mid-edited, to help answer this question. So kudos for doing that, and good luck. Well, it's been a great discussion, and I think we're hitting about the hour-long mark. I'm going to hand it over. Oh, Pino's got one question, and I'm going to hand it over to my co-moderator, Katie, to get in the last word.
Yeah, I have a question for Meredith. If this patient will choose a primary, no surgical option, so if the patient refuses transoral robotic surgery plus neck dissection, you would treat with radiation around or chemorad up front?
So the patient had T2N1 disease, is that right?
Yeah.
Yeah. So I think that is a little bit grey. Within the best of study, he'd have moderately accelerated radiation alone, so 70 gray in 35 fractions delivered over 6 weeks. Outside of that, you know, he would have old style TNM7 stage 3 disease, and you know, the McNC meta-analysis has stage 3 disease there. And granted, not, you know, HPV positive or negative, all comers in head and neck cancer showing a 6.5% overall survival advantage to concurrent chemo with radiation. And of course, omitting cisplatin in this patient population and giving cetuximab instead in RTOG 1016 and de-escalate HPV, you know, resulted in worse outcomes. So I think outside of a context of a study, I would offer the patient, if he were fit enough, concurrent chemorads.
Yes, but even because the paper of Cooper and Bernier regarding the extracapsularity and involved margin of resection were related to a whole series of advanced
Absolutely, that's, yeah.
So we have
that's the problem. It's a bit
on the HPV positive oropharyngeal cancer. Probably we cannot translate the whole conclusion of these two United States and the European study on the practice.
No, you're absolutely right. It was a mixed bag of tumors, you know, probably very few HPV positive patients there, but we don't have, you know, level 1 evidence that allows us to omit chemotherapy. And we oncologists like, you know, good quality randomized prospective evidence.
Wait a minute. Are you talking about data? Come on, man. So, you know, so we've had a really great discussion representing a lot of different points of view, and Katie, I know you're up next, but the best of study is something we didn't have time to talk about today, but it's another important EORT study that's looking at HPV positive, HPV negative tumors that our colleagues in Europe especially are still dealing with. We're seeing fewer of them here in the United States. And I direct you to Christian Simon or Simon and the EORTC best of study, just for those American head and neck surgeons who are dialing in. So thanks for mentioning that. And thanks for the lively discussion there, Pino and Meredith.
Yeah, I second that. I really appreciate everybody being on the line at all the various times of the day and night. And I think that if anything, this discussion just underscores the importance of having good relationships with all of your colleagues across the board.
Yeah.
I think we each bring with us our biases and our training. And I think it's really important that we are able to pick up the phone and call Dr. Garcia and say, hey, what do you think of this? And, in the OR, be able to call our radiation oncologist and make sure we have those discussions and communication. What are we going to do next? The last thing that I just wanted to leave us with is that I think that there is a lot we're learning. And I think a lot of the oncologic outcomes, we have to be careful about the conclusions we draw, because many of the studies, like the overall survival in 3 years, may not accurately represent the impact that things like number of nodes and ENE or a combination of those are having on the disease experience the patient is having. They may be alive with a MET, they may have not developed their MET yet. And I think we need really long-term data, and we need to be able to see all the different oncologic outcomes. But I do think that we're going to be changing, and I think we need to be willing to change from the mixed bag papers that we relied on heavily before, because this is a different disease. And I think that the equipoise is changing in a lot of our institutions based on that biology. And so I think being able to be open to thinking about that and having these discussions is really important. So I really appreciate everybody being with us today.
Thanks, Katie. Jason, I know it's getting late in Hong Kong. Thanks also for dialing in. Professor Garcia, thanks for putting up with all this surgical and oncology chatter. We learned a tremendous amount from you today, especially about ENE.
Thank you very much. Honored to be here.
Thanks, everyone. Have a great day. See you in person.
Thank you, Chris.
Thank you. Bye-bye.
Ciao. Thanks,
Bye.
Katie.
Thank you.
Appreciate it. Bye.